So I had a coworker one time who had peptic ulcer disease, and she loved coffee so much that she would titrate just the amount of coffee that she could have in a day to make sure that she could get her caffeine fix without having her peptic ulcers bother her. Peptic ulcer disease requires a lot of lifestyle changes as well as some medications, and we're going to talk all about that today as we discuss peptic ulcer disease. So what is peptic ulcer disease? Well, first of all, you have to understand how the stomach works. We have a bunch of stomach acid that's secreted and produced in our stomach to help break down food. And it's great at breaking down food, but it's extremely acidic, which can cause damage. And so our stomach has a lining on it, a mucosal lining that protects the stomach tissue and the small intestine tissue from becoming corroded or damaged by all that acid. And peptic ulcer disease happens when that mucosal lining is breached by the acid and starts getting ulcers or sores and wounds down in through the mucosal lining of the stomach or of the small intestine, the duodenum. And this breakdown of the lining happens from a couple reasons. Either too much acid is produced by the stomach or eaten, or there's some kind of breach that wears down the natural protection of the stomach lining. And those natural breaches, there's breaches to the natural protection, can be things like bacteria, specifically H. pylori. It can be stress, or it can be some medications like aspirin. So either too much acid or some kind of breach in the protective lining of the stomach causes erosion of the stomach lining or the lining of the duodenum. Now, peptic ulcer disease can be characterized by where the ulcers are. So we can have esophageal ulcers, those are in the esophagus. We can have gastric ulcers, those are in the stomach, or duodenal ulcers, which are in the duodenum, the first part of the small intestines that just after the stomach. And so they're characterized by where they're located. Now, esophageal ulcers are actually kind of their own thing. So today we're just going to be talking about gastric ulcers and duodenal ulcers. Signs and symptoms of these ulcers really depends on where they are. In fact, the signs and symptoms and the way the patient describes their complaints can really help you decide what's going on and maybe where those ulcers might be. And pain can either be triggered by food or made better by food. I'm going to show you what I mean. So here we have the differences between gastric and duodenal ulcers. So gastric ulcers are the stomach ulcers. They occur in the stomach. Pain usually happens between 1 and 2 hours after eating, and food makes the pain worse. The patient may have bloody vomit, hematemesis, or melena. Melena is black, tarry stool. And that's because it's old blood that starts in the stomach and then makes its way all throughout the intestines. So that by the time it gets down through the intestines and is defecated out, it's old, dark stool. So melena is black, tarry stools. Vomiting is common with gastric ulcers, and the patient may complain of more heartburn kind of symptoms, those upper epigastric chest pain, chest discomfort, and they may have a feeling of satiety, feeling of fullness very early in eating a meal. And unfortunately, gastric ulcers can cause gastric cancer, so there's something that needs to be dealt with. Duodenal ulcers, on the other hand, that first part of the small intestines right after the stomach, they occur in the duodenum. Pain is a little bit more delayed, usually 2 to 5 hours after eating, as those stomach contents have to make their way down to the duodenum. Now, food actually makes these kinds of ulcers better. Hematemesis is possible, vomiting of blood, or hematochezia, which means bright red bleeding from the anus. And now, because the bleeding of duodenal ulcers is closer to the end of the GI tract, it means that the patient is defecating bright red blood when there's hemorrhaging possible. So dark tarry stools is melena, more common with gastric ulcers. Bright red bleeding is more common with duodenal ulcers. Vomiting here is less common, and heartburn, the chest discomfort are also less common as these ulcers are lower down in the GI tract. Now, duodenals can cause the patient to wake up at night due to the pain. Now, diagnostics for peptic ulcer disease are done based on the symptoms as well as through some kind of scope. And it's typically an EGD, which is an upper GI endoscopy. The patient is brought into the GI lab and they're placed under moderate sedation. So they're half asleep and they don't remember the procedure. And the scope is inserted through their mouth, down the esophagus, and down into their stomach, esophagus, and duodenum. And during that time, they can take visual pictures of any ulcers they find, like the pictures you're seeing on the screen. And they can also take samples. Now, patients with peptic ulcer disease, the most common cause of that is the H. pylori bacteria. In fact, 90 to 100% of duodenal ulcers are caused by H. pylori, and 60 to 100% are caused by gastric ulcer, from the gastric ulcers. And so depending on which study you look at, you'll notice variations in those percentages. But the reality is the majority of peptic ulcer disease is caused by H. pylori bacteria. So not only when they're doing the scope can they take video of the ulcers, they can also scrape away some samples and have it tested in the lab for H. pylori. Now, if you didn't want to have a scope done, you can actually test for H. pylori in stool samples, and also there are breath samples that can be taken for H. pylori. Kind of cool. So when someone has peptic ulcer disease, it's something that needs to be addressed, because if it doesn't, it can lead to things like perforation, GI bleeding, and gastric cancer. And most of the time it involves medication management. There are also some surgical options available, and we're going to talk about all those in a minute. But first, let's talk about diet as it relates to peptic ulcer disease. Remember that there are certain things that increase the acid production of acid in the stomach, and so patients with peptic ulcer disease should reduce acid-inducing foods, specifically alcohol and coffee. And then they should also reduce things that cause stress to their body. So physical stress, emotional stress, and then things like NSAIDs, which also can erode the stomach lining. Additionally, a diet should be focused on fruits and vegetables, whole grains, basically a diet that's high in fiber and healthy antioxidants. But now let's go ahead and get into the medical management, specifically as we talk about and surgery. So medication management for peptic ulcer disease involves antacids, things that are going to lower acid in the stomach, specifically H2 antagonists and proton pump inhibitors. A mucosal protectant, which provides an extra coating on the mucosal lining of the GI tract to prevent erosion and ulceration, as well as antibiotics, because remember, the majority of these peptic ulcers are caused by bacteria, specifically called H. pylori. So let's go ahead and talk about each of those medication drug classes that we just discussed. So histamine 2 antagonists, or H2 blockers. Example of this would be famotidine. The brand name is called Pepcid. It blocks the H2 receptors in the stomach, which means that the stomach does not make as much hydrochloric acid. So it's an acid reducer. It's used for both duodenal and gastric ulcers. It can also be used for heartburn and indigestion in general. It can be administered either oral or IV. And the most common side effects are some GI disturbances, maybe some diarrhea, and perhaps a little bit of drowsiness. Nursing considerations. You want to avoid antacids when you're giving these. So antacids need to either be an hour before or an hour after, not with the medication. You're going to assess for any bleeding or bruising, and you're going to teach safety about the drowsiness, especially as it comes to operating heavy machinery or driving. And we want to encourage these patients to increase fiber and bulk and fluids to avoid constipation. And the good news is that when you start reducing the acid and allowing these ulcers to heal, ulcers typically start healing within 1 to 2 months. The next drug category we want to talk about is protein pump inhibitors, or PPI. Pantoprazole, or Protonix, is the most common, and it again reduces the acidity of the gastric gastrointestinal system. It blocks the final step in the production of the acid in the stomach. It's an acid reducer. It's used for both duodenal and gastric ulcers, as well as GERD. Again, it can be administered oral or IV, and the side effects are pretty similar to those of the H2 blockers: diarrhea, nausea, maybe a cough, and some insomnia, and perhaps a rash. Now, if you're going to be providing a mucosal protectant like sulcrafate, it needs to be at least 30 minutes before or after giving this medication. So a lot of these peptic ulcer medications need to be given separately. The pill must be swallowed whole. Don't crush it or chew it. And if the patient's having some GI upset, encourage small, frequent meals. And, of course, monitor for the side effects we talked about. Now, there are many different drug categories as it comes to antibiotics. One we're going to talk about today are the nitronidazole antibiotic drug class. Metronidazole is the most common flagell, and it is a bactericidal. It kills bacteria. And typically with peptic ulcer disease, there are more than one antibiotic used because H. pylori is kind of hard to kill. But this is one of the ones that you're going to see most commonly. It's called flagell. It's for both types of peptic ulcers, duodenal and gastric, and it's also used to treat STIs and other infections. Again, it can be administered oral and IV, and the side effects are pretty common for most antibiotics: anorexia, some GI upset, headache, and dizziness. But here's the most important thing you need to know about flagell, whether you're giving it for peptic ulcer disease or something else. Patients on flagell need to avoid alcohol 3 days before and 3 days after having this medication, or they will have projectile intense vomiting. Alcohol and flagell absolutely do not mix. So you need to ask your patient if they've had any alcohol in the last 3 days, and if they plan to have any in the next 3 days, and make sure that they're okay with not having alcohol, because it really is a pretty intense side effect. And as always, when we think about antibiotics, obtain any cultures before administering the antibiotics. We want to capture whatever bacteria or bug in that specimen before we start killing it off with the antibiotics. And then monitor for seizures. And then, of course, if we're giving anything IV, we always want to monitor the IV site to make sure that it is asymptomatic and it's patent, that there's no redness or swelling or pain at the IV site. The next drug category as it relates to peptic ulcer disease is a mucosal protectant. It's an extra coating that coats the lining of the stomach to protect the erosion of the tissue itself. Sulcrafate is the most common, and it protects the mucosal lining. It's used for both duodenal and gastric ulcers and is given orally. Some of the side effects are things like dizziness and dry mouth and nausea. And we got to be careful with our renal failure patients, as this is metabolized by the kidneys. Be sure to give it on an empty stomach, 1 hour before or 2 hours after a meal or bedtime. And don't take with antacids at the same time. And of course, we're going to monitor those signs of kidney function, BUN, and electrolytes. Now, if an ulcer is bleeding, it oftentimes has to be controlled through surgery, usually some kind of endoscopic procedure. And patients will come into the emergency department with hematemesis, bloody vomit, or they'll come in with bright red bleeding from their anus, and those will need to go emergently to the GI lab to have an endoscopic procedure to stop the bleeding. Other times surgery would be indicated is to remove an ulcer if there's concern about cancer, or sometimes they can even cut the vagus nerve access to the stomach, which decreases acid production in the stomach by about 75%. But typically patients do well with just stopping drinking coffee and alcohol and getting some antibiotics and some of these acid reducers. As always, let's go through the nursing process as it relates to peptic ulcer disease. So when we are assessing for peptic ulcer disease, we want to be cueing into some of those signs and symptoms that we learned about. Hematemesis, pain with eating or after eating, pain relieved by eating, bloody stools or melena, heartburn and chest discomfort. All of these symptoms we're going to want to be watching for. And if we suspect peptic ulcer disease, then we would, look further into diagnostics like some kind of H. pylori test, as well as maybe an EGD. In terms of the nursing diagnoses, remember, nursing diagnoses are the problems that we can identify and help with as nurses. And so nursing diagnoses for peptic ulcer disease include things like acute or chronic pain, a knowledge deficit. Maybe they have this chronic peptic ulcer and it's been bothering them for a few months, but they don't really know what to do about it, how to take their meds appropriately. And then, of course, a risk for fluid volume deficit if there is a significant amount of bleeding. And of course, active ulcer bleeds can be a medical emergency if they're bleeding significantly, or it might be something that needs to be dealt with, urgently but not emergently. Now, in terms of interventions, as always, we can assess, we can take action, and we can teach once we know someone has a peptic ulcer. So we're going to assess their vital signs and their gastric pH, because the higher the pH, the worse off they're going to be. We want to ask about their use of alcohol or other medications that can cause peptic ulcers, like NSAIDs, aspirin, ibuprofen. We're going to watch their electrolytes and do a full pain assessment, ask about diet, and take a CBC to make sure there's no infectious process going on, and also to check their hemoglobin and hematocrit if we're concerned about anemia. We can take a blood culture to make sure that there's no septicemia, bacteremia, bacteria in the blood. And then, of course, take their weight and make sure that they're maintaining a stable. In terms of actions to take, of course, we're going to maintain all IV infusions, administer those medications as ordered, being careful not to combine some of these peptic ulcer medications that need to be taken at different times. Assist with gastric lavage. Lavage is when we insert a nasogastric tube. We confirm that through pH testing as well as an X-ray to make sure that NG tube is in the stomach and not in the lungs. And then we can actually instill fluid and wash out their stomach and then suction that back out. We're going to prepare patients for the endoscopy, and that means things like being NPO, making sure that they've signed their consent forms, and then making sure they have an IV that's patent and good to go. Encourage them to limit food intake after the evening meal to decrease pain at night and when they're trying to sleep. Document and report any clinical manifestations, and of course assess and intervene for managing their pain. In terms of teaching, we want to teach our patients about how to take their medications as prescribed, avoid eating within 2 hours of bedtime, and advise them about those risk factors to decrease their risk for having peptic ulcer disease. There are a number of risk factors for peptic ulcer disease. I'm going to read off a few of them for you now. Any kind of Crohn's disease, excessive smoking or alcohol ingestion, and other medications, specifically things like NSAIDs, steroids, aspirin, and alcohol use can all be risks for getting peptic ulcer disease. Finally, as we evaluate outcomes, we want to make sure that our patients are doing better. So our patients who have peptic ulcers, when we evaluate did our care work, we should see that they have increased comfort, they have good pain control, and they're tolerating their diet. That's going to wrap it up on our discussion on peptic ulcer disease. As always, thanks for listening. We'll see you next time.